Everybody. The topic that I have been given, I think in the last 1 hours we saw significant and tremendous innovation and advancement in each field of medicine. But I think cardiology,
Bismillahirrahmanirrahim.
cardiology and
so I hope if we work together
is significant from any other field. So I will be trying to stick according to the topic which is pertinent to the internist. This is the layout of my presentation: diagnosis, drugs, and devices. What we have in recent time. A journey of 1,000 miles begins with single stop. Squeezing the fact. So, in the ever-evolving landscape of medicine, the field of cardiology is driving forward with groundbreaking advances, offering new hopes for patients with cardiac condition. Novel drugs, devices, innovative techniques, or redefining what is possible for treating heart diseases. In the past, most of the patients with multivessel disease would be treated by CABG. Now it is only 15%. Majority of the procedure being done percutaneously. So what is new changes in recent guidelines? Previously, we would call the chest pain typical and atypical. Now we have said bye-bye to it. It is either cardiac, possible cardiac, or non-cardiac. If you have a central pressure, squeezing, gripping, the probability of chest pain being cardiac is high. Conventional versus high sensitivity troponin, again, it is high sensitivity troponin is preferred because it can tell us about the leaks very early. And the patient don't have to wait for 6 or 9 hours. We can discharge the patient if it is negative twice within 3 hours. If it's borderline, then we can do other investigation like echo and CT angio. ATT has been downgraded in recent guidelines. In 2013, it was class 1 recommendation, but in 2019, because it was less sensitive and specific, so it has been downgraded to class 2B. So what we have seen previously, before we started our residency, most of the procedure would have been done by the femoral roots, and we know the patient has to lie down flat for 12 hours. Then the radial was started, and now it is distal radial. Now, a few words about angiography. When it was started first in 1958, it was considered to be gold standard, but we know this is two-dimensional. It has got a poor resolution, it is angle dependent, vessel overlap. There can be foreshortening, inter and intra-observer variation. So, fractional flow reserve was developed. It can tell us about whether the lesion is physiologically significant or not, because we measure the pressure distal, and then we take the ratio to the aortic pressure of the hyperemia. For example, this was the lesion considered intermediate angiographically just by seeing, but when FFR was done, it was significant, 0.07. So the rule of 6 or 9, this we can see, because it is two-dimensional, we can see different thing and the individual can interpret differently. So we need something to see inside the vessels. So then we have intravascular imaging like optical coherence tomography and intravascular ultrasound, which can tell us about the lesions, morphology, severity, minimal diameters, and cause the etiology of the lesions. So then we have seen evolution of stents. Initially, only balloon angioplasty would be done, old balloon angioplasty, that is POBA, then bare metal stent without any drugs. Then we saw significant restenosis rate. So then drug-eluting stents, with drug-eluting stents, the paclitaxel and sirolimus drugs was used, and there was poor polymers, so there was more stent thrombosis. Then the second generation stent, and then without vascular scaffold. So this is the evolution of stents. We have seen once the first angioplasty was done in 1977, now it has tremendous innovation in it. So recently we have seen in diagnosis IOS, OCT, FFR, CT-FFR, IFR, and CFR, and biomarkers. And drugs now, because coronary artery disease is chronic intermediate stage, colchicine has been, recently there was a data and it has got encouraging result. And in invasive, we have robotic surgery, because when we do PCI, especially the chronic total occlusion or other procedure, complex procedure, there is hazards of radiation. So in developed world, they have started robotic procedure. Another problem that the cardiologist faces is calcification. For that, we have different tools like ROTA, etc., but it is more invasive. It needs a lot of learning curve. So shockwave, intravascular lithotripsy, it is already being used in urology. So it is new innovation. Stem cell therapy, nanotechnology. So this is the guidelines. What we, after discussing what we saw, so this is the guidelines, class 1, class 2A, and 2B. So this I want to emphasize. You know, aspirin is given after 35 by most of the internists and GPs. But in recent trials, this is ARRIVE, ASCEND, ESPRI. ARRIVE was conducted in moderate risk, that was around 20%, ASCEND in diabetic, and ESPRI. In all the trials, except in ASCEND, there was slight decrease in mass, but at the cost of increased bleeding. So in guidelines nowadays, there should be no use of aspirin, except in those patients who has got high ischemic risk with low bleeding risk. This is very important. So no routine use of aspirin. Now there is data coming that if LPA, which is nowadays a very hot topics being discussed everywhere, there is a lot of data coming. If LPA, lipoprotein A level is more than 50 milligram, then aspirin is, although the study is observational, but there is slight reduction in mass. And this is very important. Calcium score can be done by CT, and it is very easy and it is cost effective. If your calcium score is 300, you have to treat that patient like established atherosclerosis. You have to give aspirin, you have to give statins. Physical activity, again, everybody should do it. 150 minutes a week, 30 minutes a day, 5 times a week. Hypertension guidelines were changed previously by the ECC. Less than 120, 180 is normal. Elevated is 120 to 129, and less than 80 diastolic. And hypertensions, previously there were a lot of stages. Now they have reduced it to stage 1 and stage 2. So in stage 1, single pill therapy, either AC or ARBs plus calcium channel blockers, or if the blood pressure is not very high, we can treat with single therapy. Step 2, against triple combination. In step 3, more than 3 drugs. The European Society of Hypertension, they have a bit different view. They have different classification of hypertension, and they have published their guidelines in 2023. But whichever guidelines you follow, you should treat the patient's blood pressure according to the targets. So in other resistance hypertension, we have seen recently there is this very good encouraging data with aldosterone synthase inhibitors. This is baxdrostates for 12 weeks, and it has shown, if it is given the responses according to the dose. If it is given at 2 milligrams, there is significant reductions in blood pressures. And the other things which was started, renal denervations. It has got some encouraging result. Then there was the simplicity trials. They did not show any improvements, but now they have been restudied, and recently it has shown some promising result. One thing which is often discussed, the timing of antihypertensive. This is the meta-analysis. We can see there is no much effect whether it is given in the morning or in the evening, but you have to control the blood pressure. About lipids, dyslipidemia. So we know about statins. It has got a significant role. Besides, it lowers the LDL cholesterol. It has got pleiotropic effects. But there is still residual risk. We have to take care of that as well. So for this, various drugs were studied. This is Odyssey outcome studies in which PCSK9 inhibitor was studied, and the patient, more than 18,000 patients were studied, and it showed, all the patients were on statin. It shows significant reduction in LDL around 50 to 60%, and there was 15% reduction in primary endpoint, that was cardiovascular death, myocardial infarction, stroke, and revascularization. Another 4-year study, Odyssey was studied in those patients who had prior acute coronary syndrome. 4-year study, this was in stable ischemic heart disease patients, and it shows significant reduction in the median LDL level was 30. And again, there was significant reduction in the primary endpoints. This clear outcomes trial, and those patients who were statin intolerant, in these patients, bempedoic acid was given, and it also showed reduction in the LDL cholesterol level, as well as non-fatal myocardial infarction, stroke, and revascularization. This is another promising drug, inclisiran, which is being given percutaneously. Orient 9, 10, 11 trials reported significant reduction in mass when it was meta-analyzed. But still, we are waiting for Orient 4 trial, which will be completed in 2026, and then result will be published maybe at the end of 2026. So this is a new concept: the lower, the better, and strike effectively. So we don't know, because in animals it has been studied, and though they have the cholesterol level, LDL cholesterol less than 30, and there is no MI in them. So we have to reduce the LDL cholesterol, especially in high-risk patients, as much as possible. And second, the concept which is new, we should, because after acute coronary syndrome, the next thrombotic events occur immediately. So we have to be, the ischemic complication is early. So we have to reduce the LDL cholesterol early to reduce the recurrence events. These are the, again, previously there was, targets, but now they have high intensity statin, moderate intensity statin, and low intensity statin. So this is secondary prevention of atherosclerosis. If the patient has got established atherosclerosis, we have to treat that patient with high intensity statins if the age is less than 75. If more than 75, then moderate intensity statin is acceptable. But again, if the patient's physique is good, we can consider him or her for high intensity statin. But if the patient has got very high risk, then every patient has to be on high intensity statin. For primary prevention, if the patient LDL cholesterol is 190 or more, we don't do risk stratification, and the patient has to be on high intensity statin. Every diabetic patient has to be on moderate intensity statin and should be considered for high intensity statin treatment. And for the rest, we have to do the risk stratification. If risk is more than 20, patient has to be on high intensity statin. Few words about valvular heart disease. Again, previously it was classified according to severity, but now they have been divided, reclassified according to the stages. Stage A only risk factors, stage B mild to moderate valvular disease, and the patient is asymptomatic. Stage T is further divided into C1 and C2. C1 LV function is normal and patient is asymptomatic. C2 patient has got LV dysfunction but again is asymptomatic. Stage D, the patient is symptomatic. If we do surgical SPR, then the patient, if less than 50 mechanical value is reasonable, more than 65 bioprosthetic, between 50 and 65 we have to individualize. We don't give, it's not recommended to give vitamin K antagonist after 3 months of bioprosthetic valves. This is the TAVR, which is, it was first done in 2022. Now it is being done in Pakistan in many centers. Atrial fibrillation, 12 lead ECG is class 1 recommendation. Nowadays, most of us wearing Apple Watch, it can detect atrial fibrillation. Pillar of AF management, it is very important. First, we have to assess the stroke risk. Second, we have to modify the risk factors. Third, we have to quantify the AF burden, which is very important. So then, shared decision making, we have to inform the patient, because this is very important. We are giving anticoagulation, and it has got its own adverse effect. How we can risk stratify the patient, we have different risk scores, Jabbar score, Atria, and Garfield. So if the patient has got thrombotic risk more than 2%, this is Jabbar score more than 2 in men, more than 3 in women, we have to anticoagulate the patient. How we can anticoagulate? If this patient who has got more than 2% risk of thromboembolic phenomena, we have to anticoagulate. DOACs is preferred unless there is some contraindications or warfarin. If there is contraindication to anticoagulation, then we have to consider these patients for LA closure device, which is being done in Pakistan, and it has been being done in RAC and in Peshawar PIC. Few words about heart failure. The heart failures, this is a battery of trials which was started in early 70 and 80 and 2022. So the revolution, the ERNI, the SGLT2 inhibitors, which was initially considered and trialed in a diabetic patient, but what they found that there was significant reduction in heart failure hospitalization, irrespective of their diabetes. So now it is considered one of the 4 pillars of heart failure medications. So this is a new strategy. Previously, conventional sequences, that is, we should start the patient on AC inhibitor, beta blocker, MRA, ERNI, and then SGLT2 inhibitors, and it would take 6 months. The new concept that you start the patient in step 1 with beta blockers, SGLT2 inhibitors, add ERNI, and then in step 3 MRA. But it should not take 6 months. It should be done within 4 weeks, within a month. So cumulative impact of evidence-based heart failure with reduced ejection fraction. In this study, in meta-analysis, it was shown a relative reduction of 73%, absolute risk reduction of 26%, and number need to treat only 4. So if you combine all the medicine, these 4 pillars, we can achieve this much reduction in relative and absolute risk reduction. So it is what we know is a drop, what we don't know is an ocean. Thank you very much. If there is any question.